Good morning, everybody. Happy Thursday. It's bittersweet for me because, as the team knows, I probably won't be seeing many of you until 10 days from now as I go on a vacation with my family. But I can't imagine a better way to say a temporary goodbye to VMR with really an all-star academy lineup today. I get to discuss with Maddie, who I will just really introduce her in very simple terms. Maddie has um, started from really being a VMR member to really defining what the future of CP Solvers looks like. She is a currently the co-director of internal operations, the director of VMR, director of the subspecialty series, and many, many, many other things. And so while she will feign humility and try very, very hard to do so, she really is spearheading us into 2024, 2025, and ideally, if I had my way, 2050, but we'll see how that goes. And with Maddie in the spotlight is Parisa, who's one of our first recruits in 2024 to the CP Solvers Academy. And I don't think she's missed a single VMR. If she has, she probably felt really bad about it, which is so telling of Parisa. And I'm really, really excited to share the stage with you all and say a temporary goodbye to VMR. Well, I'll pass the mic to you, Maddie, to say hello, and then we'll jump in to learn from Parisa's case.
Yeah, good morning, everyone. At least it's morning where I am. And I'm so excited to discuss today. And CP solvers in general, but VMR in particular, is such a joy in my life. And so it's always a huge privilege just to tune in, but getting to discuss is even better. Yeah, and I'm so excited to learn from the case, Parissa, that you are going to present to us. And Rabih, we will definitely miss you over the next week, but we'll keep VMR going.
All right. Let's start the case then.
Oh no,
Uh,
Parisa. No, 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 no. Tell us a little bit about you
I
first.
should introduce myself.
Oh my gosh, you're so formal and professional. The ultimate
Yeah.
professional.
My name is Parisa. I think the VMR is the best hour in my day. I would love to start morning with VMRs, and I'm really excited for every single moment with you all.
That's so sweet. Okay, now we can be serious.
We can jump in. I will start with the chief complaint and a bit of HPI, and then I will give it a pause. The case we have here is an 84-year-old male who admitted to medical ICU while he is intubated after a PEA cardiac arrest. The story started when he presented to the hospital with weakness causing fall and change in his speech after swallowing a fish bone 5 days ago. He was found to have severe dysphagia, esophageal dysmotility, and he was candidated for PEG tube replacement. It's worth mentioning that he recently managed for Klebsiella UTI complicated with bacteremia. While he was pending for tube placement, he had another aspiration event, which was followed by cardiac arrest. Unfortunately, this episode developed acute kidney injury for him. For the review of system, we are not able to obtain any more information from him. I need to give it a pause here.
Hey, man, this is a very tricky place to start. I'll just kind of summarize where we're at for everybody listening and give you a moment to think about it. Like the scene before us right now seems to be an 84-year-old man who's intubated. And the reason he's intubated is he just suffered PEA arrest. And the context that we're given is very much focused around two leads, severe oropharyngeal and potentially esophageal dysmotility and a UTI with bacteremia from Klebsiella. But I think what we know now is he just suffered a PEA arrest, and it's probably presumed that it's from an aspiration event. So, I think in 2 months' time, you'll be in this situation. I'm really curious if you were there in that PEA arrest. How do you think about that space and what crosses your mind?
Yeah, no, first, I'm so grateful for you presenting this case because, when I heard PEA arrest, I definitely started developing some tachycardia. So this is this is why VMR is so helpful, because we get the time to kind of reflect on this in a controlled setting so that we're more prepared in real life. So I'm really appreciative of you bringing this to me. And so for PEA arrest, for cardiac arrest, one of the ways I think about it are, there are the H's and T's, which I've heard about it, but I actually think I watched a video that Rabih created on RL or CB solvers that broke it up into some, I think you described it as like microscopic versus macroscopic causes, and that's differentiated by findings on POCUS. So if we start, macroscopic causes, and those are some that POCUS would be revealing of. So for example, you could use POCUS to see, is there a PE? Is there a pneumothorax, for example? Or is there a tamponade that could be the cause of his PEA arrest? Or on some of the microscopic causes where POCUS would not be as helpful, you could think of some electrolyte abnormalities. So is there severe acidosis, or is there very high hyperkalemia? And then in the vitals, is like there's severe hypoxemia, for example, or is there some med or toxin on board? So I found that, when I learned it from your video, Rabih, I found that really helpful, because it really kind of shows how, it illustrates how POCUS can be really helpful in seeing if there's a obstructive cause that could identify this, or do we, scanning the vitals to see if there's some abnormality there, looking at the labs to see if there's a severe acidosis or hyperkalemia, and if maybe either from history to see if there are any meds or toxins on board. So that's, I still have a lot to learn about cardiac arrest, but that's my understanding of kind of how to approach it. And now I'm looking at the rest of the history to see, what further progress we can make. So so it's interesting, the patient came in with weakness and fall, change in speech, and then there's this history of dysmotility, and then a recent UTI. And so I think I'm going to wait to make more progress until we get more information, because in this history, I'm not exactly sure which to grab onto that may be contributing to the PEA arrest, and which is noise for the dominant problem. But I think I'm kind of keeping all these in the back of my mind, and we'll pull on these threads as we get more information. But Rabih, I really would love, as someone who has a lot more real life experience with PEA arrest, would love your advice.
Yeah, no, I think that I think that the transition that you had between understanding PEA arrest in such rich detail, you literally remembered everything. And I'll pull up a visual for everybody. And then to realize that ultimately everything else is really hard to make progress on in significance, and we'll talk about that too. But ultimately, I think we should all really realize that the reason we break down PEA arrest, cardiac arrest into PEA arrest versus a shockable rhythm is actually a practical one. We really want to identify which people are in cardiac arrest for something we can rapidly reverse, which is an arrhythmia that we can shock somebody out of. There is no other benefit to stratifying arrest this way, apart from teaching and emphasizing that VFib and VTAC or a shockable rhythm should be just shocked right away. And so when you think about PEA arrest, what PEA arrest means is that it's just not a shockable rhythm. And what it stands for is there's pulselessness, which we already know, electrical activity. So the other scenario is pulselessness, bad electrical activity. And that's all the progress you've made. So the question becomes, how can you be pulseless despite a normal rhythm? And that really comes down to two fundamental concepts. You have a mechanical issue that you can see with POCUS. Either there's no blood at all, empty chambers, or the blood is being blocked by a large pneumothorax or a large pericardial effusion or a large pulmonary embolism. Or there's a key concept that even though there's nothing in the way physically, and there is blood, you're still not ejecting. And that gets at a concept called electrical mechanical dissociation. And the idea there is that despite good electricity, the bridge between the electrical signal and the cardiac contractility is down. And if you think about what it takes to translate electricity into myocardial function, you'll really realize that the milieu that the heart is in requires there to be certain parameters for efficient transfer of electricity to muscle contraction. And if there's a beta blocker in the way, no matter how much electrical signal, your muscles won't contract. So beta blocker overdose. If there is a perturbance in the electrical balance, if there is a low temperature, and all sorts of things. So let me show you the visual. And this is where the H's and T's and all that stuff comes from. But the goal is to understand why somebody would PEA arrest is ultimately, there, as you said, there's a video on RLR CP solvers, but ultimately, is it macroscopic? You can see it. Or is it microscopic? And this gets at why does electricity not talk to the muscle? Can because there's a toxin in the way. There's some core vital sign abnormalities that impair that transfer. There's electrolyte issues. And then actually in advanced AL amyloid, you have so much amyloid between the conduction system and the heart muscles that you can't transfer that electricity. So I think in this person, Maddie, we're given the hint that he had a witness aspiration event. So the leap of faith that we're going to make is that the patient had really bad hypoxemia. And that's why they PEA arrested. And I agree with you. I think there's too much dust. Right now, we have to wait for it to settle. Oropharyngeal dysphagia in an 84-year-old is very common as a sequelae of neurological conditions like dementia. Recurrent UTIs are also very common because of BPH. What isn't very common and what deserves exploration from the get-go is esophageal dysmotility. That is an unusual finding in anyone. And so I think we'll have to tug on that thread no matter what, and we'll see if the bacteremia is of significance or if the oropharyngeal dysphagia is actually unexplained by a previous neurological condition that the patient has. So yeah, I agree with you. I think we just have to see how things settle out. Most dysphagia, oropharyngeal dysphagia, and most recurrent UTIs have very specific reasons in patients of this age, but we'll have to make sure that those reasons are present. And if not, maybe tug on those threads even more. Any questions about any of that, Maddie?
No questions right now. And I'm curious to see kind of, as you said, what threads prove helpful as we get more information from Parissa.
It's always amazed me how you are connecting dots together, and it was a really great masterclass. Thank you. I will give you information about past medical history and the medication he is on. He has a history of CBA, he has ESRD, and he had bilateral renal transplant. He has AF, and he also has biventricular pacemaker placement. He has hypertension, hyperlipidemia, and he has heart failure with preserved ejection fraction. He has diabetes type 2. He also has peripheral artery disease, and he underwent bilateral femoral artery angioplasty. He also had prostate cancer, and he underwent radiation. In terms of his medication, he is on amlodipine, aspirin, atorvastatin, edoxaban, linezolid, hydralazine as needed, and he's also on prednisolone and tacrolimus for his renal transplant. In terms of his family history, there is a cardiac history, cardiac disease history in his mother, and there is a history of cancer in his brother. He has a 3 years history of smoking, and I will give it a pause here.
Awesome. Thank you so much, Parissa. And thank you, Gia, for describing this really, really rich case. Yeah, Maddie, what crossed your mind with this additional information?
Yeah, so I mean, I think the takeaway is that this patient has quite a rich past medical history. And, you know, some of the things that stood out to me is the bilateral renal transplant that he's on immunosuppressive therapy for that. And and I'm also noticing the amlodipine, just because, you know, we just talked about some of the medications that can cause cardiac arrest, and calcium channel blockers being one of those. So, the things that I took away was that this patient has a really complicated past medical history, and that he is likely immunosuppressed given the medications he's on for the renal transplant. So just, keeping that in the back of my mind to see if that will play into this current presentation and if that's related at all. And that he does have quite a significant cardiac history as well with the pacemaker and HFrEF. So right now I'm trying to see if this past medical history can help us make progress on, for the cause of the PEA arrest. I think, the leading, right now, one of the ways we're putting together was from hypoxemia from potential aspiration event. And I don't think this past medical history changes that for me. It puts me just a little bit on more of alert because he is on an immunosuppressive regimen, but no other progress, at least from me, besides that. And
Love it.
I'm curious where you're at.
Yeah, no, I think that this is superb. I think we should take a moment to talk about what we might do in the moment with the PEA arrest. And I think I'm glad we saved this conversation for this moment, because now you really can replicate what you might do if you were there in the PEA arrest. And I'll just outline the big picture, and then we'll fill in the details of the dialogue. And the big picture is that there really are 4 phases of a code blue. The first is to actually forget about what the cause is and to take over the patient's circulation. And you want to do that by first making sure that you have been given permission to take over the patient's circulation by assessing what the patient's code status is. And that's key. You don't want to perform this really physically demanding and consequential procedure on somebody without their previous consent. And the way we take over a patient's circulation is we place a backboard behind them, and we connect them to the monitor to make sure that if it's a shockable rhythm, we shock them. And then we begin CPR. It's the first and most important thing, right? And so we can talk about quality of CPR, but once code status is established, the backboard's behind the patient, you've begun CPR. Now you're making sure the patient is semi-stabilized. In this instance now, you will very soon know whether the patient has PEA or whether they have a shockable rhythm. I'd recommend that you prepare for empiric treatment of both conditions. And your pharmacist will be very savvy with this by preparing epinephrine, and in some circumstances, preparing amiodarone for a shockable rhythm that is refractory to shocks. And in that way, you're just prepared for non-specific treatment of the conditions. And you have the patient hooked up to the monitor. You're doing CPR. You've got the epi, you got the amiodarone ready. And then every 2 minutes, you're going to pause, do a pulse check and a rhythm check. You're going to see if the patient has their pulses returned, and you're going to see if what the rhythm is and if it's changed between a shockable or non-shockable rhythm. So that's kind of the routine. That's phase 1 of just like getting into you're going into. The second phase is empirically treating things based on suspicion alone. So if you think the patient has a PEA arrest secondary to, oh, by the way, I should say one thing that we don't actively do that our anesthesia team does is, of course, intubate the patient because they can't protect their airway. So this is happening, but this is usually not the code leader's responsibility at that time, though technically everything's your responsibility. So you want to keep track of that. And then there are parameters for advanced parameters for effective compressions with end tidal CO2 that anesthesiologists place. But we can talk about this forever. But the second phase is like empiric treatment based without any diagnostic data. And so you might empirically treat a patient. In this patient, you might use his end-stage renal disease as a clue to think about hyperkalemia and start to empirically treat his hyperkalemia with IV calcium as an example. You might worry about him having a blood thinner on board, and any hint of any bleeding anywhere might push you to start the massive transfusion protocol without any further data. If the patient were on QTC prolonging medications, you might empirically give them magnesium for that possibility. So empiric treatment is a phase. The subsequent phase is really to use your ability of point-of-care ultrasound to visualize any macroscopically apparent issues, which we talked about. And then the final phase is to send off blood work to see if any of the electrolyte abnormalities are at play. So if you go through that, the first phase is a routine that you should get in every patient. The second phase is empiric treatment. The third phase is macroscopic visualization, and the final phase is sending off data for electrolyte repletion, or for diagnostics, like hemoglobin, potassium, and VBG, VBG to look for the acid base status. So any thoughts about the secondary category? Any empiric treatment that you would consider doing right now based on the risk factors that he has? And I'll pull up the schema for you to see at the same time.
Yeah, I think given what you said with the ESRD and the risk of hyperkalemia, I think, starting the IV calcium treatment is definitely something that I would do here. He's also on some blood thinners as well. So I think being prepared for massive transfusion protocol makes sense as well to me. And
yeah,
those are the two.
Yeah, agreed. Yeah, agreed. I don't think I would execute the massive transfusion protocol because it's a big cumbersome thing, but I think you'll have a hemoglobin in a bit, and you'll also have to be open to the possibility that the hemoglobin may not reflect acute bleeding if he just bled out right now into his GI tract, for example. And then, yeah, I think the POCUS is going to be really, really key. The POCUS is pretty good at identifying a pericardial effusion and a pneumothorax. It's harder in such a crass situation to identify a pulmonary embolism. So to be honest, stage 5 is often, I haven't found anything else, and this patient has cancer, and I'm worried about a PE, and empiric TPA is given in a small fraction of these patients. So I just want to outline the phases. Phase 1 is supportive initiation of external resuscitation. Phase 2 is empiric treatments. Phase 3 is electrolytes. Phase 3 is point of care ultrasound. Phase 4 is blood testing, and phase 5 is a really consideration of TPA for pulmonary embolism that was not detected. And so here, I think we're in a situation where the patient's been intubated, presumably because of hypoxemia, but we don't know that. I think we should be systematic about all these phases to make sure we don't miss anything. If we end up being convinced that the aspiration and the hypoxemia cause the PEA arrest, we can then move on to understand why the patient's aspirating. But I still think that connection is a weak one, and one that needs to be verified by assuming nothing else is going on. All right, Farisa, tell us more, please.
Amazing. In this alicot, we have the exam. His temperature is 36.3 axillary. His heart rate is 65. His blood pressure is 127/68. His respiratory rate is 28, and he's saturating 100% at room air. In his examination, in general, he's unresponsive. He has a fixed pupils. They are unreactive. His oral mucosa is moist. A tube feeds content noted around his nostril and oral mucosa. In his cardiac exam, he has a normal rate and regular rhythm. There is no murmur, no edema. In his lung exam, there is bilateral coarse burst sound. In his abdomen exam, his abdomen is soft, non-tender, non-distended, and there are positive bubble sound. No costovertebral angle tenderness is appreciated. In his neuro exam, he is unresponsive, and he does not, unfortunately, respond to deep sternal rubs or voice commands, and he does not withdraw to pain in all his extremity. I will pause here.
I know, Farisa, that this is a case given to you, Rabih. I'm just curious if you happen to know more. Is he intubated right now, or is he still?
Yes, he is. I think he is intubated still.
Okay. So then I think that really helps because, gosh, he hopefully has been given. So this is after his PEA arrest, correct?
Yes, it is.
Yeah. Gotcha. So we're in the ICU. He's intubated. He's probably sedated, hopefully. Otherwise, we have to really worry about why he's not responsive at all. But yeah, I'm curious, Maddie. So you're in the ICU. He's intubated. He's sedated, and he's got this exam. What would cross your mind?
Yeah, so overall, clearly, even from the history, we were quite concerned, but I'm very concerned about this patient. I think the things that stood out to me are the fixed non-reactive pupils, as well as the bilateral coarse breath sounds. And for the bilateral coarse breath sounds, that there was a concern of an aspiration, and so I think that heightens that even more. I would want to get image, maybe even POCUS probably would be most efficient. So I would probably want to start with POCUS of the lungs just to understand that more, but almost certainly wanting to get some imaging of that. And so I'd probably, start with the POCUS, but would probably ultimately want to get even a CT scan to better understand what's happening in the lungs. The heart rate I noted is just as slightly low, but to be honest, I think right now I would want some basic labs, an EKG, and some POCUS images before making more progress.
Yeah, I completely agree with you. I think we really have to do all that for sure, and really do it very quickly and effectively. Why don't we step out of this space and just go into a mental exercise of saying impaired neurological status, just as a loose term, status post-code. What thoughts would cross your mind about somebody who has just been coded, is intubated and sedated? Hypothetically, we don't know if you got any sedating medications, but let's just assume that in these situations, sometimes it's really hard to know. So status post-code, intubated and sedated. What kinds of thoughts would cross your mind as to be explanatory for why this patient is in essentially a coma?
Yeah, I mean, I actually think I saw a patient with like anoxic brain injury from after a code. So I think that's the first thing that crossed my mind. That would be really a concern.
Yeah, agreed. I think that ultimately what you're trying to do when you're doing effective compressions is to prevent anoxic brain injury from happening. So what we're doing in that first phase is we're trying to get effective circulation to the brain. And hopefully while we do that, really somebody else is doing that with their hands. You are using your brain to figure out what happened and to prevent it, to bring back the circulation online so the person using their hands can stop. That's what we're trying to do fundamentally. And so here, when you have a neurological compromise after the code, you're really wondering, I just thought of a way to teach it, which is why I go back to the pre, intra, post, because I've never really I haven't written the schema for this, but there really is one cause pre, one cause intra, and one cause post the code. The post the code is the medications you gave the patient to sedate them. The intra is, of course, as you said, the anoxic brain injury. But there's important to recognize that there could be pre-code issues. And the pre-code issues could be a neurological catastrophe, like a subarachnoid hemorrhage, an intracranial hemorrhage, an ischemic stroke that caused the patient to aspirate, that caused them to have PEA arrest. So I think that in these circumstances, when the patient is this comatose, you probably would never accept any amount of sedating medications making this patient this deeply encephalopathic as a first pass hypothesis. So I think you have to trace your steps back and make sure there was no pre-event or no intra-event. And the pre-event would be any neurological catastrophe. The intra-event would be an anoxic brain injury. With effective circulations in a witness aspiration event in the hospital, the probability of anoxic brain injury is lower because the patient presumably is pulseless for much less time than they would be in the field. And presumably there are trained people doing effective circulation. So in a patient like this, the probability of a pre-code intracranial disaster is higher than it would be otherwise. In most patients, cardiac arrests are not from neurological issues. They do happen. But when it happens in the hospital, the concern for a pre-code issue goes higher. So neuro plus impaired neurological circumstances plus code pre, intra, post. And I think here, I think we have to exonerate a pre-cause. So in addition to scanning this area anatomically, now that we can get POCUS and or CT scans, I think a trip or a scan up here will be very, very helpful too. Any questions about that?
No, that makes sense. And I think I was just scanning the chat and saw Rob's highlighting the prior CVA and the potential hypercoagulable state with the cancer history, just as further reasons to scan the brain as well.
Dr. Weber is a smart man, that's for sure. All righty, Farisa, tell us more.
At first, sorry, I think the room air was a reflex word.
Yeah.
I will give you
No
lab
problem.
data in this aliquot. His white VC is at 2000. His hemoglobin is 11, and his platelet is 106. In terms of his chemistry, his sodium is 142, his potassium is 4.1, his bicarbonate is 18.5, His creatinine is now it's 1.39 and the baseline was 0.7. His calcium is 10.3, magnesium 2.2, potassium 2.1. His lactate is 5.6. His PT is 19.1. His INR is 1.6. His creatinine clearance is 25. And his troponin is 654. And his ABG, the pH is 7.39, PCO2 31, PO2 87, bicarbonate 19, and FI2 of 70%. And his AA gradient is at 359. His anion gap is also 8. They didn't, I do not have a brain CT scan from him, but I do have an EGD, which is revealing an 8 millimeter gastric ulcer, which was successfully managed with clipping and catheterization. I also have a chest X-ray that I would like to share with you.
Want to give it a crack, Maddie? What do you see? I think on the left, I would imagine is pre-code. And then on the right is post.
Yeah, so what I'm seeing, what's standing out to me is bilateral infiltrates, most in the lower lobes compared to the upper lobes, I believe. The costophrenic angle is clear on both sides, so I'm not immediately concerned for a pleural effusion. The heart size it does not look enlarged to me, and I'm not seeing any signs of pneumothorax. So I think the main thing that's jumping out to me is bilateral infiltrates. What's standing out to you, Rabih?
Yeah, no, absolutely. Yeah. As a reflex, do you think that the infiltrates are in proportion to the severity of the situation, or are you a little underwhelmed?
I'm a little underwhelmed.
Yeah, right. Yeah, we'll talk about that. I think what's also helpful to do is if you look at the pre-image, do you think you can, what lines do you identify? External things that are going into the person on the left.
Yeah, is that a pacemaker that I'm
Yep,
seeing?
that's the pacemaker. And then you see that there are two endpoints. There's
Right.
one that ends in the right atrium and then one that ends in the right ventricle. So this is a dual lead chamber pacemaker.
Mm-hmm.
Do you see any additional lines on the right?
I do see
Yeah, what do you see?
additional lines. I'm not sure what they are, but
Yeah, give it a shot.
I
Give it a
see
shot.
quite a few extra lines.
Yeah.
What are we seeing here? So
Yeah. There are a lot of tele leads on top.
yeah,
So you can see they're not really going anywhere. But try to look in the trachea. What do you see in the trachea?
so he's intubated here.
Yes. And
Yeah.
what do you think about the quality of the intubation? Is it dead center or is it going one way?
No, it's not dead center.
Yeah, where is it going? Do you know?
Is it going to the right?
Yeah.
Yeah, the right.
There's a right mainstem intubation here with the ET tube veering towards the right. It's much more common. The same reason the ET tube goes to the right is the same reason we aspirate towards the right. The angle, the more acute angle of the right mainstem bronchus really attracts things towards it, including an ET tube. So one important thing with this X-ray is to be underwhelmed by the interstitial infiltrates and to pull back the ET tube by a little bit so we can appropriately ventilate both lungs. But thankfully, the patient doesn't seem to have suffered collapse on the other side. But I think, this is the tricky thing about aspiration is about 30% of patients with aspiration pneumonitis, which is the diagnosis we'd be invoking, don't have any X-ray findings. The aspiration is small and chemical, and so you need a CT scan to see it. And the question I think before us is, if the patient was really hypoxemic beforehand and the X-ray doesn't provide sufficient explanation, does that mean that there is no parenchymal issue, or does it mean that the parenchymal issue is too subtle to be appreciated on X-ray? And so I think with the tube feeds in his mouth, it's hard to not believe that he had a severe aspiration event, but to recognize that the sensitivity of X-ray for acute aspiration pneumonitis is very low. And so in this circumstance, I think a CT would be explanatory and to help you assess for the possibility of a pulmonary embolism. I think when we learned that he had a gastric ulcer, we have to really realize the value of a single hemoglobin and to make sure that we don't use a single hemoglobin to exonerate hemorrhagic shock and to trend it. But I'm curious, did any other lab values jump out to you?
Yes, so they did. So we're seeing, you know, taking what you just said into account, like the single hemoglobin, all the cell lines are down. So translating that to pancytopenia, and just to kind of call out the concerning things, and then we can try to incorporate. So
Yeah, always make a list first.
let's just make a list and then we'll figure it out.
Yeah.
So there's a pretty significant AKI as well, from the baseline of 0.7, now 1.39, an elevated lactate, an elevated troponin. The bicarb is also slightly low. The pH, if I'm recalling, was normal. And the potassium also is, you know, we were tracking that as well to see if hyperkalemia was a part of this, which we're not seeing. So I'm, you know, with the elevated lactate, I'm concerned for, you know, like the thing you want to be most concerned about is some end organ damage, and that's further supported by the elevated creatinine. Concerned about, you know, myocardial injury with elevated troponin, and those are the things that stood out to me.
Yeah, I think you're absolutely right. It's really hard to distinguish clues to the code from the consequences of hypoperfusion. And I think that's the theme that you're seeing here, Maddie, is the person's confused and not responsive. Is that because something happened before, or is that the fact that he had no perfusion? It's almost shocking to have no lactate, no AKI, no troponin after a code. It must mean you were delivering flawless chest compressions, which is literally impossible. So what we really try to do in these circumstances is we try to see, well, what do we expect? And we really expect all the organs to be injured in some way, shape, or form simply because the patient was pulseless. But we're really studying very closely to try to see, are there any asymmetric findings that are out of proportion or unusual to help us latch into a specific cause? And marked hyperkalemia, potassium of 7 would jump out. Just really bad anemia would jump out. But otherwise, I think all these things are easily explained by the consequences of being pulseless. So I think what you're probably doing here is you're standing and you're saying, okay, no clear cause has emerged apart from the fact that I saw tube feeds in this person's mouth. I'm going to assume it's aspiration. But if it is really aspiration, the patient should have a smooth course with only respiratory issues and not any other hemodynamic issues in the future. So one really powerful thing is what happened in a patient who just died and was resuscitated. What is the natural history of that? And will they improve with the treatments we offered? And the only treatment we've offered right now is securing the airway. And if securing the airway and oxygenating the patient results in a smooth, stable course, then I think you can assume that it was an airway issue that led to the compromise. But if there are subsequent twists and turns, we will be open to them being consequences of having been coded, like your kidneys go offline, or that they might actually be clues as to what happened. So I would not reduce the value of the natural history that will unfold before us. If things are smooth, we've only done one thing, one definitive thing, which is securing the airway. If things aren't smooth, we'll have to categorize them as consequences of being pulseless or as the original cause themselves. All right, Parisa, what do you have next?
I will give you his POCUS, which is showing right ventricular dilation and strain. In this hospital course, he also developed melanotic stool leading to severe anemia, which required multiple blood transfusion. And his eroxaparin was discontinued, and he was put on PPI inhibitors. And his I will pause here because next Alicot has the final diagnosis.
Awesome. There we go, Maddie. We found some things. Can I just ask? I know we're inclined to move over to the next phase of this, but I just have to say that that kind of like 5-pinned approach to code is probably what you're gonna find most valuable in the mountains of Colorado. And I'm really curious if you wouldn't mind just like going through that just to really reinforce it, because hopefully we'll be able to find an answer on that pathway. What do you think?
Yeah, definitely. So correct me as I go along, and I
Yeah.
tried to jot down some notes as you were talking. So we're talking about a code blue, the cardiac arrest. And so there are 5 phases that you outlined. So phase 1 is kind of external resuscitation. So that's when you place them on the backboard, connect them to the monitor, and then check their rhythm to figure out if it's shockable or not. So the shockable ones are pulseless ventricular tachycardia or VFib, and then or you have PEA arrest. So phase 1 is, and then when you're beginning CPR. The phase 2 is empiric treatment, and we talked about some examples of that, hyperkalemia in the setting of ESRD, where you can consider calcium. You can think of preparing for massive transfusion protocol if someone's on blood thinners. Stage 3, I believe, is POCUS. So that's when you're looking for some of those macroscopic causes like PE, tamponade, for example. 4 is blood testing. So that's when we're looking for some of the lab abnormalities that we talked about. So extreme hyperkalemia, acidosis, for example. And then 5 is TPA if basically you're concerned about PE. So
That's
I'll pause there,
scary.
Rabih, if you want to add.
Did you all see that? She remembered the average rate of retention is about 25%, actually like 27% of new content learned. But I think Maddie is 4 times that. But anyway, yeah, sorry, what were you saying?
Well, I just wanted to see if you wanted to add
No,
anything.
I don't have anything to add. You got it all, literally.
All right.
Yeah.
Well, so here we're seeing the thing that jumped out to me is POCUS, the right ventricular dilation and strain. So I'm concerned about a pulmonary embolism. Why is that right ventricular dilated? And there's likely some kind of pulmonary hypertension or occlusion in the pulmonary artery. So my highest concern right now is for a pulmonary embolism. So I'd want to get CT angiography to look at that. And then I definitely need to learn more about kind of the timing of intervention and things like that. But like, would you give TPA and kind of the order of operations for that? I know I have a lot to learn on that, but highest concern for a PE right now, and would want to get imaging for that and then potentially start TPA. Yeah.
I completely agree with you. I think that that we really should translate this into a concern for pulmonary embolism. Well, let's talk about 2 questions. The first is like, as you're thinking about PE and you're thinking about treating the patient for TPA, you also learn that the patient is having ongoing GI bleeding, right? And so I think balancing those 2 things is really tricky. I'm curious what thoughts you have about that. Like, if you imagine it to be the most serious circumstance where you're thinking about PE based on this POCUS, but you literally see the patient having melena right in front of you, to make it as stressful as possible to be able to then extrapolate it to less stressful situations. What might you be thinking in that circumstance?
No, that's a really tricky situation. And I mean, I don't exactly know how to balance those, because you have you're suspecting a big clot likely in the pulmonary arteries, and that can be deadly. But then also you're seeing signs of a GI bleed, and so giving a blood thinner would not help that GI bleed. So I'm not sure how to balance those. My immediate reflex, which I'm not sure is accurate, is that the PE is potentially much more deadly. So wanting to yeah, I am very uncertain about this. I'm not quite sure how to balance it.
I think nobody would be certain what to do, but I think these are circumstances where you extend beyond our typical treatments for pulmonary embolism, which is to think about anticoagulation, to really realizing that some people offer mechanical therapy, including thrombectomy for pulmonary embolism. So we'll see if we use that. But basically, when we're trying to take care of a pulmonary embolism, ongoing hemorrhagic shock is a contraindication to TPA. It will really probably cause the patient to collapse hemodynamically. And so you just remember to tap into your bucket of the fact that there are interventional and CT surgery-based treatments for mechanical thrombectomy. And so in these patients who are actively bleeding with an ongoing severe pulmonary embolism, what you can do first is place an IVC filter to prevent further clots from coming from the legs, presumably. And then also think about the category of mechanical treatment for pulmonary embolism as you manage the GI bleed separately. This is also in certain very high resourced academic centers, there's role for ECMO or extracorporeal membranous oxygenation, which requires anticoagulation, but may be able to temporarily support the patient. So here, I think there's a couple of things. The first is to really realize that in a patient with a respiratory arrest, the increased right ventricular dilation and strain is definitely the result of high pulmonary pressures. The question is are the pulmonary pressures the result of a clot, or are the pulmonary pressures the result of hypoxemic vasoconstriction? Which is why when you use your POCUS, you always have to be cautious about the value of diagnostics for PE, because a pericardial effusion is much easier to appreciate, a pneumothorax is much easier to appreciate. A PE, you'll never be sure, especially in a hypoxic code, where the RV dilation may be simply from the hypoxemia. So that's going to be something in the back of your mind. But in the circumstances, if there was as serious as possible with the patient bleeding and we see this finding, I think this is a circumstance where you call interventional radiology and CT surgery for the questions of how to mechanically support this patient. But I do think that in a patient with active cancer, trying to stabilize them enough to go to the CT scanner at some point to look for a pulmonary embolism is really, really key. And the ultimate lesson that you're teaching us here is that that an aspiration event is not diagnostic of the aspiration as the cause. There could be some proximal issue that's making the patient unable to eat and swallow effectively. All right, Parisa, I'll give the mic to you. What did you all find?
Great discussion. It's really hard to believe that Maddie still is not a resident. I think she is way too much more. The patient was unstable to have the BQ scan, and because of his acute kidney injury, the CTPE was deferred. He underwent echocardiography, which showed normal ejection fraction, right ventricular dilation, regional RV dysfunction with apical sparing suggestive of acute pulmonary embolism. And the ultrasonography also showed extensive bilateral lower extremity, DVT thrombosis extending from common femoral to popliteal vein. And the final diagnosis is pulmonary embolism. He was a candidate for, because of his complicated situation, he was candidate for IVC filter placement, and he is currently on hemodialysis.
Really unfortunate case of a very devastating and very hard to diagnose condition. You'll find that pulmonary embolism, it is an end diagnosis of many workups. It's an end diagnosis of chest pain, an end diagnosis of PE, meaning that we often have to go through many other things before ultimately getting a CTPE. I would just say that the findings that you're seeing on CT on the POCUS are a little bit more specific to PE. The finding that Parisa just shared with us of apical sparing with RV strain is called McConnell's sign, and it has much more specificity towards a pulmonary embolism than just RV dilation without that apical sparing. And so, yeah, I hope the patient continues to do well. It's a very, very tricky thing to suffer a PEA arrest from a pulmonary embolism. Thoughts, Maddie?
Yeah, I mean, I think my main reflection is just how grateful I am for VMR and for this case, because I definitely felt very uncomfortable talking through this. And I think that's the whole value of sessions like this. I know I'm definitely going to read a lot more about code blues and, PE management and treatment. So to be more prepared for a real life setting. So I'm just very, very grateful. this opportunity.
I mean, I
And
think,
Carissa, I
oh,
just
yeah.
had one question. So we were talking about, the challenges of managing the PE in the setting of this GI bleed. So I know you mentioned the IVC filter. Do you have any other information about how the PE was managed and treated kind of acutely?
I do not have. Sorry.
Oh, no, no worries, no worries.
Yeah, I think in these circumstances, sometimes all you can do is to put an IVC filter in and cross your fingers and prevent more clots from coming through. The body will naturally start to dissolve clots as you go, and in very unique circumstances, you can offer mechanical therapy. But if you were to anticoagulate a patient who's bleeding this badly, it'd probably be very risky. So sometimes all you can do is to do no harm by placing an IVC filter. But then sometimes you can mechanically retrieve the clot if possible. Yeah. Yeah, I think Maddie, it was really cool to see you really jump in and think through this case. And I do think these situations are very, very stressful. So you often have to have a checklist of what you're going to do, and hopefully that hopefully that 5-phase approach, which I find very helpful, can come in handy. Parisa, it's really hard to present a case that you didn't see, and I think you told the story in such a really engaging way. We got to learn a lot. So thank you so much for doing that. I'll pass the mic to Kushal to take us home with the teaching point.
Amazing case and with so much of learning points, but the most important ones which I thought was, one was the cardiac arrest and how to approach it. And there's an amazing schema on CP Solver's website which says about microscopic causes like metabolic acidosis, and which can't be seen by focus, and macroscopic causes which focus is going to be helpful. The second one is how the code itself is follow through, which the first is phase 1, where you connect the patient to the monitors and assess whether it's shockable or non-shockable rhythm, and that CPR is done. And for rhythms which are not responsive to shock, ambient rhythm is also given. And phase 2 is when encourage treatment for plausible causes. For example, in this patient, consider hyperkalemia because he's got end-stage renal disease. And phase 3 is to do the focus, and phase 4 send the last stat, and phase 5 is give an empiric dose of TPA for PE, which is not visible but focus. And the third point which I had was for acute aspiration, the sensitivity of the chest X-ray is very low. And the next one which I had was when the patient is having an RV strain as well as dilatation and focus, we have to see if it's because of pulmonary embolism or because of hypoxia itself.
Ah, laughs. Wow. Like distilled down to its pure elements. Thank you so much, Kushal. I really like how concise and crisp that was, and emphasizing the 5 phases. Thank you. All right, y'all have a wonderful rest of your week. And I look forward to seeing you all soon. Bye.